Hi guys, we are going to talk about chapter 28. This is going to cover child, older adult, and intimate partner violence. So the first paragraph of this chapter really caught my attention, so I'm just going to read it. There's no place like home. This is a statement familiar to most of us, and home is a source of refuge and peace for many. Yet for some children, adults, and older adults, the home is a dangerous place where family members or intimate partners demonstrate disregard for the rights of others. So let's get started here. There are 5 different types of abuse that we're going to talk about. Physical abuse, which is that infliction of physical pain or bodily harm, things like slapping, punching, hitting, choking, biting, or burning. Sexual abuse, any form of sexual contact or exposure without consent or in circumstances in which the victim is incapable of giving consent. Emotional abuse is the undermining of a person's self-worth. This could include humiliating, name-calling, intimidating, or isolating. Neglect is failure to provide for physical, emotional, educational, and medical needs. And economic abuse is controlling a person's financial and economical resources. This could include forbidding school attendance to keep a person dependent. Anyone can be at risk for abuse in a crisis situation. Situations that put stress on a family with a violent member, especially one with no impulse control, problem-solving skills, and no healthy support system. The term perpetrator applies to any household member who is violent towards another. This could be a parent, sibling, or extended family. Perpetrators often consider their own needs to be more important than anyone else's. And then the vulnerable person is a family member upon whom abuse is perpetrated. Other terms can include victim, survivor, or victim survivor. The term survivor recognizes recovery and healing process that usually follows victimization. Child abuse can take the form of something improper done to a child, which is act of commission. This is a deliberate and intentional. They include physical, sexual, and emotional abuse. An act of omission or neglect occurs when a child's basic physical, emotional, or educational needs are not met, or when a child is not protected from harm. Acts of omission include physical neglect, emotional neglect, medical and dental neglect, educational neglect, inadequate supervision, and exposure to violence. As far as epidemiology, 2.4 million referrals for child abuse and neglect were reported in 2018. And you can see the alarming numbers on this slide. And the unfortunate reality is that these numbers have probably increased since the pandemic. I think the most disturbing one is the last one. About 92% of child abuse perpetrators are the victim's parents, which makes sense, right? Because that's who they live with. Unfortunately, 78% of deaths with child abuse are children younger than the age of 4. And again, the pandemic did us no justice with our child abuse numbers. As far as comorbidities, the occurrence of one type of abuse is a fairly strong predictor of the occurrence of another type. Secondary lifelong effects can include anxiety, depression, suicidal ideation, major depressive disorder, and PTSD, which are the 2 most prevalent disorders resulting from childhood trauma. Risk factors for child abuse include the child is seen as different or even fragile. The child may remind the parent of someone they didn't like perhaps an ex-spouse. Sometimes children don't live up to the parent's fantasy or what the child should be like. Child is the result of an unwanted pregnancy, or there's that loss of emotional bonding that was interrupted due to either prematurity or prolonged illness. Intimate partner violence is abuse within the context of an intimate partner relationship where one partner asserts power and control over the other. This power and control can include physical violence, rape, stalking, and psychological aggression. You can see as far as epidemiology there, 25% of women and 10% of men are abused. Teen dating violence is about 1 in 11 females to 1 in 15 males. Let's see, same-sex relationships, same rates as heterosexual relationships. And then 1 in 10 homicides is usually a spousal murder. So this is the cycle of violence. We start with the tension building stage. So these are minor incidences, maybe pushing, shoving, or verbal abuse. The victim typically ignores what's going on at this time, or they accept it because they don't want more to happen. Then as the perpetrator moves into the acute battering stage, more tensions peaking, emotions are high, some type of external event triggers the abuser. Brutal beatings can occur in this stage before they move into that honeymoon stage. And this is where kindness and loving behavior start occurring. The abuser may feel remorseful and the victim may feel very guilty. Unfortunately, without intervention, the cycle will repeat itself. Older adult abuse, older adults mistreatment is really defined as that failure to provide basic needs and failure to protect. Abuse may be inflicted physically or sexually. Financial abuse is big with our elderly population. This is a problem because those caretakers may steal cash or credit cards, or they may coerce the older person to transfer funds. Older adults may lose personal belongings, such as vehicles, medications to that caretaker. The Center for Disease Control and Prevention estimates that about 1 out of every 10 adults older than the age of 60 who live at home are victims of abuse. This number may be far higher in that for cases reported. For every case that's reported, 5 go unreported. So that really could be even greater than 1 out of every 10. The lack of reporting may be due to isolation, dependency, or fear of retaliation by that elderly patient. Further complicating the picture is that the older adult may be caring for him or herself, which creates the potential for self-neglect. Abuse occurs in both institutional and family settings. Family members are often the perpetrators in most of these incidences. So let's apply the nursing process to this patient. So we know that the first step in the nursing process is assessment. We'll do a general assessment, remembering we may be working with some patients that may not be able to verbalize things for themselves or even want to. Symptoms may be very vague, or complaints may be about chronic pain, insomnia, hyperventilation, or even gynecological problems. All assessments should include questions related to a history of sexual abuse, family violence, or drug use or abuse. As nurses, we want to gather information by asking really good questions. What we want to do is make sure we provide for that patient a calm, relaxed environment, and we are accepting of whatever they're going to say. When we are interviewing, we want to sit near that patient, establish that trust and rapport relationship. We want to avoid words like abuse or violence. We want to ask how disagreements are settled, how children are disciplined. And we want to avoid assumptions about a person's sexual orientation. During the assessment, you will always want to use the term partner versus husband or wife. So assessment should also include violent indicators. What's the level of anxiety and those coping responses? How is the family cope? What are the family's coping patterns? What does the support system look like? Is suicide or homicide a potential? And is there any drug or alcohol use? Assessing for physical abuse, minor complaints such as headache, back trouble, dizziness, and falls may be covert indicators of violence. Some of the overt signs may be bruising, scars, burns, or other wounds in various stages of healing. We want to observe for nonverbal responses, such as hesitation or lack of eye contact, remembering that vague explanations serve as a warning for further investigation. And then look for that nonspecific bruising, especially in our older children. That's very common. Bruises on infants younger than 6 months should be considered suspicious. Shaken baby syndrome is the leading cause of death from physical abuse and usually occurs in children that are less than 2. Signs of sexual abuse in children. We can think about sexualized behavior. That's the most common symptom of sexually abused children. Younger children may have precocious sexual knowledge or explicitly talk or images. Sometimes they'll even demonstrate sexual aggression. Another telling sign includes acting out sexual interactions. Other signs are masturbation or sexual promiscuity in our older children population. Other consequences from childhood sexual abuse is PTSD symptoms, somatic complaints, or feelings of guilt. So as we continue looking at these different abuses, assessment for emotional abuse can exist on its own or in conjunction with physical or sexual abuse. Some key identifiers include low self-esteem, reported feelings of inadequacy, anxiety and withdrawal, learning difficulties, and poor impulse control. Neglect, appear maybe undernourished, dirty, poorly clothed, inadequate medical care, maybe they don't have all of their immunizations, or maybe they have an untreated medical or dental condition, and those would be really good examples of neglect. And the last one is economic abuse, and again, that's just that failure to provide for those needs. So assessment variables can include anxiety. So again, we're watching the nonverbals. That can be a key indicator of how anxious the victim is. We're looking at coping mechanisms. Most coping mechanisms are used by individuals in order to endure living in violent situations. Are these coping mechanisms flawed beliefs or myths? We'll look at their support system, which could be very limited or not even accessible. What is the suicide potential? The victim may feel desperate to leave, yet trapped leaving, so suicide is really their only option. The homicidal potential, so we want to make sure we're assessing for a safety plan for when the violence recurs. The abuse is always a potential for lethality. And the last one there is drug and alcohol use. Victims may self-medicate with alcohol or other drugs just as a way to escape. So as far as assessment documentation, it should include verbatim statements of who and when. So if your verbatim statements, make sure those are in quote. We'll look at a body map to indicate size, color, shape, areas, and types of injuries with those explanations. And then we also want to make sure we have physical evidence of sexual abuse when that's possible. We also want to make sure we're doing some self-assessment. Working with these patient population can be very intense and overwhelming. We can have very strong negative feelings that could cloud our judgment and interfere with our objective assessments and interventions. Common responses of healthcare professionals to violence is very, we're not going to like those violence. perpetrators. So as we keep moving on, after obtaining our assessment, we can analyze our findings. While many of the analysis are directed toward protecting vulnerable family members, we also need to make sure we're including our perpetrators in our plans of care. Table 28.4 identifies signs and symptoms, potential nursing diagnoses, and outcomes for victims of child, intimate partner, and older adult abuse, as well as for individuals who do abuse. Outcomes should be to reduce or reverse the problem addressed. So whatever the problem is that you are analyzing, our outcome is going to address that problem. So the nurse is often the first point of contact for people that are experiencing abuse. The Joint Commission requires that staff is educated in family violence and abuse. They also have a development of standards of care to guide clinical practice, as well as having protocols in place for child, intimate, and older abuse. Plans should center around our patient safety first, and then discuss with patients if possible. The child may be removed from the home into a safe space or place. And then we need to consider the needs of the abuser as well, if they are motivated. As we intervene as nurses, we know that nurses are legally mandated to report suspected or actual abuse. Consider the family's culture. This is important because it is central to how people organize their experience. If there's a language barrier, the nurse should speak slow and make sure they're not using any medical jargon, and also consider a trained interpreter. As far as counseling, this could include crisis intervention measures. A safety plan for rapid escape should be developed when the abuse may recur. If the survivor of intimate violence chooses to leave, shelters or safe houses are available in most communities. Case management will help the victim or survivor navigate medical, criminal justice, or social services. And then promotion of community support, health teaching, and health promotion. Remember, we want to role model behaviors for our patient. So prevention of abuse, we can talk about primary prevention. This consists of steps to help prevent the occurrence of abuse. We can identify those at high risk and provide health teaching and coordination of supportive services to hopefully prevent the crisis. Strategies include reducing stress and the influence of risk factors and increasing our support system, coping skills, and self-esteem. When we think about secondary prevention, this is early intervention in an abusive situation to minimize long-term effects. So sorry, guys. And then the last one is tertiary prevention, and this happens after the abuse has occurred. Now, as nurses, we are looking at the rehabilitation process and providing support and maybe getting them into some safer situation. Treatment modalities, psychological therapies will include individual, family, and group therapy. And that concludes chapter 28. If you have any questions, you can shoot me an email or we will chat about it in class. Thanks, guys.